Hi guys, this is Dr. Deepak Marwah. Good to see you guys back. I hope you're staying safe in these difficult times. Today, I shall be discussing highlights of the 2020 American Heart Association guidelines for cardiopulmonary resuscitation. So let us dive into the wealth of this information. Let us study regarding what's new. First and the foremost, they have spoken regarding double sequential defibrillation. Before I go into whether it is beneficial, not beneficial, does it reduce mortality, I need to explain to you what they mean by the word double sequential defibrillation. You can see on the monitor, the display is showing that the patient is having a ventricular fibrillation. This patient has already been given not one, not two, but three sequential DC shocks. In spite of that, the patient is still in ventricular fibrillation. So I have two options, either to let go because already sufficient time has passed by and there would be a substantial irreversible brain damage, or as a last ditch effort, what I can do for this patient is to hook up two defibrillators to the single patient. Now, when I say this, I know you would be grinning and saying that, sir, in India, getting one defibrillator for one patient is big deal. And here you're talking about hooking up two defibrillators to a single patient. Yes, I'm talking about two defibrillators to be hooked up to a single patient. Well, how would you do that? You see, defibrillator number one, you would put the paddles in the standard fashion as is shown in the image here, the red one. You can put one paddle that would be on the right side, right upper sternal border, and the second one at the cardiac apex, so no big deal. But then you need to put paddles of the second defibrillator also, and you can put the paddles of the second defibrillator medial to where you have placed the paddles of defibrillator number one. Please ensure that the paddles of defibrillator 1 are not touching the paddles of defibrillator 2, because if you do that, if they're touching each other, there's a possibility that you will fry up the electrical circuits of these expensive gadgets. Therefore, one of the approach that can be used is also that one of the paddles can also be placed posteriorly. The bottom line is that you are placing two defibrillator paddles on the patient. They should not be touching each other. There should definitely be some margin clear between the defibrillators to prevent any frying of electrical circuits. Well, this approach has been aggressively used in previous few years for patients of refractory ventricular fibrillation. It looks very fancy. When I discuss about it, a lot of students say that, sir, when triple sequential defibrillation is coming? Well, the American Heart Association currently has put a cap on this, and they have said very categorically that double sequential defibrillation has not shown any reduction in mortality. So the first message for today's discussion that I want you to take home is that double sequential defibrillation, it means that two defibrillators are hooked up to a single patient. They are not firing at the same time. It's like first shock, then immediately a second shock. So because you're delivering a higher energy, obviously that would cause local damage also. But if you're delivering a higher energy, you are hoping that the person gets converted into a normal sinus rhythm. But now they're saying that all this fancy stuff, well, they have not supported. He says this does not reduce any mortality. So the first message, and important from exam perspective, would also be that double sequential defibrillation is not useful. Coming to the second take-home message, which is with respect to epinephrine, and an important one. I want you to pay attention to this particular diagram. You see, whenever we are talking about CPR, we are always talking about a shockable and a non-shockable rhythm. For shockable rhythm like ventricular fibrillation, you obviously give a DC shock, no big deal. But you can see that to highlight early use of epinephrine in the patient, they have put a image of a syringe here and have mentioned the fact that epinephrine should be given as soon as possible. If you look at the discussions of the previous years in the app, whether you're listening to me or anybody else, nobody is talking about epinephrine being given as soon as possible. They are just mentioning epinephrine is to be used. Line is that they have used the word as soon as possible, but when it comes to pediatrics, and listen to this aspect very carefully because they have made some very fancy and very, I would say, radical changes in pediatric resuscitation as well. In pediatric resuscitation, he has here mentioned that epinephrine is to be given within 5 minutes. In adults, there is no such time limit defined. He has just mentioned ASAP, as soon as possible. But from exam perspective, I want you to remember that when it comes to a patient having a asystole, that is a non-shockable rhythm, In children, he has mentioned epinephrine within 5 minutes of CPR initiation. So that's definitely an important message to be taken care of, apart from the previous information that I provided regarding a double sequential defibrillation, which is currently not supported. When I talk about epinephrine in cardiac arrest, it is understandable. Why are you using it? You are using it because you want to stimulate the SA node so the heart rhythm will come back to normal. But you can see that we are also using epinephrine in patients of ventricular fibrillation and ventricular tachycardia. We anyway use epinephrine even in ventricular tachycardia and ventricular fibrillation. I have a question for you guys here. You see, in ventricular fibrillation or in a ventricular broad complex QRS tachycardia, the heart is already running. So what is the point of giving epinephrine? I mean, the SA node is still gonna be firing when the basic treatment for this chap should be DC shock. Please appreciate why are we giving epinephrine in these patients is primarily because of the fact that in this case, epinephrine has been shown to enhance the coronary perfusion. If you enhance the coronary perfusion, you will reduce the ischemia, and you know the fact that ischemia is the main villain or the trigger behind development of a ventricular fibrillation or a ventricular tachycardia. So epinephrine is to be used both in shockable and non-shockable rhythms, but when you use it is different. In case of a person who's having asystole, a person having a non-shockable rhythm, you are gonna give it ASAP, whereas in cases of ventricular fibrillation, you would first deliver a DC shock. Obviously, the CPR is already been given. One team is already working on CPR, but then once the CPR has been given and the person is not responded, when you deliver the second shock, you also have to deliver epinephrine. The advantage is enhancement of coronary perfusion, reduction of ischemia, and a definitive improvement in the chances of survival, in return of spontaneous circulation, and neurological recovery is also improved. Now, before I go to point 3, which is regarding neuroprognostication, they have highlighted regarding the biomarkers which can be highlighting that the patient is recovering. You are very well aware, if somebody goes into cardiac arrest, somebody develops a ventricular fibrillation, if the blood supply to the brain is gone, even if you save this guy, a lot of your patients in recovery phase will be having a status epilepticus. It could be convulsive status epilepticus. It could be non-convulsive status epilepticus. So how are you gonna prognosticate them? How are you gonna manage them? I'm definitely gonna speak about it. But before I do that, I would like to use this opportunity to highlight regarding some of the aspects which have been very dramatically changed in pediatric resuscitation. So before we talk more about the adult fact, I am just gonna dedicate 2 minutes into some highlights with respect to changes in pediatric resuscitation as well. One, you are aware of the fact, I would call myself old school because, I belong to the previous century. Now, what I was taught was that in children, and this information is not valid anymore, that subglottis is the narrowest part of the airway when it comes to little babies or children. So we should be using non-cuffed tubes when it comes to children at least less than 7 to 9 years of age. But look at what the 2020 guidelines are. He has categorically mentioned that choose a cuffed endotracheal tube even for infants. They have talked about using a cuffed ETT, a endotracheal tube, to be preferred, and I'll just show you snapshots of the same as well. But before that, I would just like you to remember that currently, even for infants and for children, they are not talking about uncuffed tubes, because earlier the concept was that of possibility of subglottic stenosis developing in a person, but currently the risk is very low. So the important highlight, apart from the aspect of epinephrine, which I've highlighted, should be given within 5 minutes of CPR initiation. In adults, there is no timeline mentioned. He has mentioned ASAP, but in children, it's gonna be within 5 minutes. He has also recommended cuffed endotracheal tubes to be used over uncuffed endotracheal tubes, both in infant and children. Now, when you read this for first time, obviously the first impression of everybody or the first thought process of everybody is that would it not contribute to local damage? But the current generation of tubes that we are using are basically high volume, low pressure tubes. The advantage of these high volume, low pressure tubes would be that there would be definitely relatively less chances of subglottic stenosis. The guidelines are that the cuff pressure should always be kept less than 20 centimeter of water. So that figure, if you can remember, that is great, along with this gross data of using cuffed endotracheal tube even for infants and children. Then they have also mentioned that with respect to children, cricoid pressure is not recommended. So I'll just highlight that statement. The basic concept is that if you are using a cuffed endotracheal tube, the chances of aspiration will be lesser, and cricoid pressure does not reduce the chances of aspiration. I repeat the statement. I said cuffed endotracheal tube will reduce the chances of aspiration, true, but cricoid pressure will not reduce the chances of aspiration. So no need of cricoid pressure when it comes to children. And one of the very striking things and the highlight of today's discussion is that when it comes to once you have intubated a child, once the advanced airway is in place, then the ratio of rescue breaths that are to be given will dramatically change. The older guidelines were, listen to these words very carefully, the older guidelines were that approximately one breath should be delivered every 5 to 6 seconds. So that means that you would be delivering approximately 10 to 12 breaths per minute to the child. But in the new guidelines, they have highlighted the fact that you in advanced airways, you see, you have already intubated, you need to provide to the patient one breath every 2 to 3 seconds. So if you calculate this mathematically, the number of breaths will dramatically go up. That is between 20 to 30 per minute. So that's definitely a change in data from what it was present earlier. Additional point I would also like to add to this discussion is regarding the comeback of steroids. Well, I would like to call 2020 as comeback of the steroids, because you see, one, in COVID-19 pneumonia, in patients who are hospitalized, steroids have shown a dramatic improvement. Second, they have also talked about steroids being useful for pediatric septic shock. You see, earlier we were reading that steroids are having a equivocal role, but now they're saying that in a case of septic shock who is non-responsive to fluid resuscitation and you have already used vasopressors, you can definitely be using steroids, and they have definitely shown a reduction in the mortality. What are the vasopressors which are recommended here in pediatric age group? It is epinephrine and norepinephrine. And if epinephrine, norepinephrine is not available, we can use dopamine. You see, when I say that, a lot of you would say, sir, we have read about dobutamine being used first line. I've highlighted that even in my routine lectures, that dobutamine is not recommended even in Harrison for patients of adult patients with septic shock. Even in septic shock patients in adults, he has first talked about norepinephrine. He's talked about dopamine, but not about dobutamine. So when you talk about vasopressors, it is mainly norepinephrine and dopamine. And why that is so is mainly because norepinephrine increases diastolic blood flow, and that will enhance the blood supply when it comes to the coronary circulation. These are some guidelines which I definitely want you to remember from the pediatric domain. And once you have gone through this, let's dive back into the original aspects that I was talking about. You see, I'll just show you a couple of snapshots which are important since they have mentioned about it. One, they have mentioned regarding for pediatric patients, and just making it as an overall discussion, because otherwise you see in the exam, if I say, okay, I'm going to discuss only this part and not another, then obviously you would not be getting a complete picture. In fact, I will also be today talking regarding a patient having a cardiac arrest when she's delivering a baby. They have included that in the current discussion. So please appreciate they have highlighted that you need to have a holistic view. You need to have an overall view of the data rather than saying, okay, adult again, different, child again, different, neonatal different, a pregnant lady different. They're saying have a holistic view, a overall view, a bird's eye view of the entire data, so that you can answer questions better and you can handle your patients relatively better. So one, these snapshots are highlighting the fact you can see that the cricoid pressure during intubation is not recommended anymore when it comes to pediatric patients. He has highlighted very gross thing, use of cuffed endotracheal tube is preferred over the uncuffed tube. Keep the pressures less than 20 as I've highlighted, whereas earlier the concept was that you can use either the two, and preferably the older guidelines were used non-cuffed tubes, but now he's talked about specifically cuffed tubes to be used. When it comes to rescue breaths in children, once advanced airway is obtained, the current guidelines are, and I've already shown and written that data before you, it's going to be one breath every 2 to 3 seconds, so it's 30 breaths per minute, whereas earlier the older guidelines were something in the range of a slightly lesser value, you see, a relatively lesser value. So you just need to remember this guidelines, which are definitely updated. And now we will focus on the main adult aspects, which will help you understand this information better. In the adult resuscitation, they have added a sixth chain. What I mean by the sixth chain is that earlier there were 5 components when we are talking about a person having a IHCA or a OHCA. IHCA would mean in-hospital cardiac arrest, OHCA would mean out of the hospital cardiac arrest. They have just included the word recovery here. I'll explain the recovery component. I'll talk about neuroprognostication that they're doing. but I want you to get an insight of this diagram, and I would like you to take a snapshot and keep it with you, because in the kind of questions that they ask in AIMS, they can ask you to arrange in the correct order. Now, when I talk about IHCA, that is in a in-hospital cardiac arrest, what is the first step that you're going to do? That is going to be early recognition, because you need to identify which are your patients who can definitely be requiring resuscitation. You can basically prioritize. But when it comes to OHCA, obviously out of hospital cardiac arrest, you can never ever know that who's going to require a cardiac arrest. I mean, there's so many people at an airport or so many people at a railway station, which person will collapse, you can't predict. So when it comes to OHCA, first step would be activation of a emergency response. Why I'm saying that is because of the fact that they can ask you to arrange them in the correct order. You can notice the fact that activation of emergency response is the second step in hospital cardiac arrest, but out of hospital arrest, the first step is gonna be activation of emergency response. Then obviously is the standard CPR which would be provided to the patient, but then you can see a difference here. If it is out of hospital cardiac arrest, like for example at Indira Gandhi International Airport, a person was boarding the flight, at the boarding gate the person collapsed. In those circumstances, this person will be given CPR maybe by a CISF constable. This CISF constable may be only 10th or 12th pass, but because he has received CPR training, he has given basic CPR, maybe even deployed the AED, which has defibrillated the patient. But now this person will be rushed to the hospital in an equipped ambulance. Once the person reaches the hospital, you would obviously take care, and there would be post-cardiac arrest care being provided to the patient. You see, till 2015, we were having 5 components only. The components were what are sequentially mentioned here before you, but now you can definitely see that they have decided to add a 6th chain, that is going to be aspects to recovery. So let me now explain to you what are the aspects that he means by recovery, and it will be better, instead of drawing on this diagram which is already on the slide, I will try to explain it on a hand-drawn diagram before you, because that always will make relatively better sense. Assuming the fact that in a OHCA, that is out of hospital cardiac arrest, versus IHCA, that is a in hospital cardiac arrest, you have successfully resuscitated a patient, and there is a ROSC, that is a return of spontaneous circulation. Once there is a return of spontaneous circulation, you need to basically understand regarding what are we going to do for our patients. Well, the first step would be targeted temperature management. When I say targeted temperature management, it means therapeutic hypothermia. Therapeutic hypothermia means that you will lower the temperature of the brain, because if you decrease the temperature of the brain, what will happen? The metabolism of the neurons will decrease, and if the metabolism of neurons will decrease, the energy requirements will decrease, and if you decrease the energy requirement of a cell, then those cells can survive relatively better. So please remember, what they're doing here is that they're dividing this time zones into return of spontaneous circulation, first 24 hours, then the first 48 hours, and then would be the next 72 hours, which are critical for the patient, and survival will depend upon how you manage in this particular time. Because as I explained, if a person has had deprivation of blood supply, he can be having status epilepticus, which could be convulsive or non-convulsive. So in the first 24 hours, what you're doing for the patient is called as targeted temperature management. This is an alternative term for what we call as therapeutic hypothermia. In therapeutic hypothermia, with decreasing the temperature of the brain, if you have listened in the routine app, I have talked about therapeutic hypothermia also in cases of raised intracranial pressure. I spoke about Michael Schumacher. He had a nasty crash, he had a head injury, and he was provided targeted temperature management. So definitely, that ensured his survival, that helped him recover from a head injury. Obviously he'll never walk and talk again, he'll never race a car, but then therapeutic hypothermia is useful in raise ICP and is also useful for patients in post-cardiac resuscitation care, because decreasing the temperature of the neurons will decrease the metabolism, energy requirements, and therefore cells will survive relatively better. After 24 hours, we will be doing rewarming, and then subsequently we will be ensuring a normal temperature, that is controlled normothermia will be ensured in the patient. So this is itself a MCQ statement. Targeted temperature management is important. Now during this phase, you need to image the patient. You need to obviously determine how much damage is there. We will also be running EEG on the patient, and we will also be using biomarkers, and that is very interesting, the aspect of biomarkers here. One of the important biomarker that they've talked about is called as neuron specific enolase in 24 to 72 hour period after a patient of cardiac arrest is being taken care of. You see, traditionally, all of you are aware that NSE, neuron specific enolase, is what you read with respect to neuroblastoma in pediatrics, and you read for neuroblastoma with respect to tumor marker of oat cell cancer or small cell cancer of the lung. But today I'm telling you that neuron specific enolase in this particular case is gonna rise. It's a biomarker that's gonna rise. Why? Because of the dying neurons. You see, once the blood supply to the brain is gone, anything after 4 minutes, any intervention that you do after 4 minutes, the neurons are anyway dying. So the levels of neuron specific enolase will definitely help you know whether this person, what kind of recovery can be anticipated. If you will do EEG of the patient, you would be able to notice SSEP written. SSEP would mean somatosensory evoked potentials. Subsequently, if I want to introduce the bad prognosis here, then after SSEPs, I can also write the word burst suppression pattern. In fact, when a person goes towards the status of brain dead, that is when burst suppression pattern, and then there would be complete silence that would be present. So if you read or if you are encountering these kind of patterns occurring, that definitely means a bad prognosis. Initially, in the first 24 hours, the imaging he has recommended is a CT scan, and the subsequent time the imaging that is mentioned is a MRI. And this was actually this diagram that I was talking about, where he has talked about neuroprognostication in adult patients after cardiac arrest. He has talked about biomarkers like neuron specific enolase. He has talked about clinical manifestations of myoclonus or status epilepticus, somatosensory evoked potentials. He has talked about MRI in a patient. So these are basically new steps because we are focusing on the recovery component. Remember, I just told you there is a sixth component added in the entire chain of management of a person undergoing a cardiac arrest. Right from the time when you identify he's going to have it, you're going to activate the response. Everybody is going to be there with respect to code blue. CPR is going to be given. You're going to defibrillate the guy, post cardiac arrest care, and then the recovery component is what I've highlighted before. Earlier, we were just casually using the word post cardiac arrest care, but now they are including this word neuroprognostication with respect to patients after cardiac arrest. So that is something that is definitely to be taken care of. And another domain that I would like to add and is present in this document is with respect to cardiac arrest in pregnancy. I highlight once again that they have tried to make this document as a holistic approach rather than focusing on only one domain, that okay, I am going to resuscitate an adult, another person is going to take care of a child, another person is going to take care of a neonate, a third person is going to take care of a pregnant lady. They're saying have a holistic approach. So let's just have a quick look at why could you be having a cardiac arrest in pregnancy and what are the interventions. So they mentioned a mnemonic. Let's just quickly look at the important components of this mnemonic as well, which can be remembered from A, B, C, D, E, F, G, H. So alphabet A would definitely stand for anesthesia. You see, anesthetic drugs can definitely have their toxicity, and there's a possibility that during anesthesia a patient has gone into cardiac arrest. So you need to take care of certain interventions, which I'll explain to you. Then excessive bleeding postpartum scenario can contribute to issues. Then could be that this lady is having a pre-existent heart disease and she's having maybe, let me say, bleeding, or her heart disease is itself getting compromised at the time of delivery, so she can go into cardiac arrest. She's having a pre-existing valvular lesion. Then can be drugs like lignocaine was injected into, like you are using lignocaine for giving episiotomy. So you always have to withdraw the plunger. Now, if you inject lignocaine into a blood vessel, there's a possibility that it can affect the heart. So therefore the role of drugs comes in. Then can be embolism. That could be because she's already having a heart disease like atrial fibrillation. The embolus could go through the brain, or it could be embolus going into the aorta and then going in the coronary artery. You see, if you are having a thrombus in the atria, the thrombus can not only land in the brain circulation, it can land in the coronary circulation also. Then could be high grade fever. Then could be general indications. Now here what I mean by the general is the standard 5H and the 5Ts. The 5H and the 5Ts I have described in the routine lecture of pulseless electrical activity, so I'll not go into them. And alphabet H would stand for hypertension. Now, when I talk about this A, B, C, D, E, F, G, H, I want you to remember what are the interventions that he has mentioned. So in the next slide, I'm going to talk about what are the indications or interventions that you would be doing from the mother's perspective. and what are the interventions that you will be doing from the fetus perspective. First, we talk about maternal interventions. In a pregnant lady with cardiac arrest, one of the foremost thing to be taken care of first is not circulation but is airway management. You see, she's having a baby inside, and the baby is gonna press on the diaphragm, and pressure on the diaphragm would limit her ventilation. So what they're highlighting is that if a lady is having a cardiac arrest at the time of delivery, management of her airway is highly important. You need to provide 100% oxygen, and you can definitely obtain an advanced airway. He also mentions that the IV line that should be obtained in this lady for delivery of adrenaline should always be above the diaphragm. That's again a very categorical statement. The IV line should be secured above the level of the diaphragm. Maybe you can try a jugular access. If magnesium sulfate is being used, like she was a patient of eclampsia and she was being given magnesium sulfate, then magnesium sulfate should be stopped immediately and the antidote should be given. I think all of you are aware what is the antidote for magnesium sulfate toxicity. You are gonna give calcium chloride to the patient. So these are a couple of newer things that they've highlighted in the statement that they've issued in this month of October, and that's why I'm making a video on the same. From the fetal perspective, I would just like to say, though I would let the OBGY consultant to talk about it. The fetal intervention is obviously to plan a perimortem cesarean section, and that should ideally be done within how much time. So ideally you should at least be in a planning stage for a perimortem cesarean section if there is no return of spontaneous circulation in the first 5 minutes. You see, brain dies after 4 minutes, so they have kept the threshold as 5 minutes. The point is perimortem cesarean section to be planned or performed. This is preferably ASAP, as early as possible, and the cutoff is within 5 minutes if there is no ROSC, that is no return of spontaneous circulation. So before I go into the subsequent aspects, I would like you to just reflect on what are the points that you've learned till now, because if I speak more points, there is a possibility that you may not remember them at all. First and the foremost is what they've highlighted is that double sequential defibrillation is not supported. That was the first point I highlighted. The second point that I highlighted before you at the moment was with respect to epinephrine. They put a injection symbol here and mentioned epinephrine to be given ASAP, as soon as possible in adults and within 5 minutes in babies. And then I dedicated a separate slide where I spoke for about 2 minutes with respect to what are the changes in the pediatric resuscitation, and they're very, I would say, dramatic as compared to what was present relatively earlier. Then I have spoken regarding the addition of the sixth chain. That was the third point that I highlighted today before you. That is the aspect of recovery, and in recovery they have talked about what we call as neuroprognostication. Subsequent about neuroprognostication, where I've spoken about neuron-specific enolase, I have highlighted regarding the aspect of what is the steps to be taken for cardiac arrest in pregnancy or at the time of delivery. And one of the important highlights is airway management, because the diaphragmatic mobility of this lady is lesser, and the IV line should always be secured above the level of the diaphragm so that the delivery of drug to the heart can definitely be assured. The point that I've highlighted here is introduction of early CPR for a patient who's having a presumed cardiac arrest. Let me explain the statement to you so that you can understand this better. Let us assume that you are at the airport and a patient has collapsed. I'll give you two scenarios. First, you need to think like a doctor, and then you need to think like, let me say, a CISF constable at the airport who is having to give a basic resuscitation to an elderly person. So first, let's look at from a doctor's perspective. I'm describing a 75-year-old elderly man. He's a known case of diabetes mellitus. He took his insulin in the morning before he was going to the airport, but because he was in a rush and there was traffic jam, etc., so he did not get anything to eat. So when he arrived at the airport, he was feeling a little dizzy, but because he had to check in and the check-in counters are gonna close very soon, especially nowadays in a COVID scenario, so this person was hypoglycemic and then he collapsed. Now, for you and me as a doctor, you can understand that if a person having hypoglycemia is collapsing, you don't need to give chest compressions to the patient. You need to straight away provide sugar to the patient, maybe with help of a IV access, and this man will recover. But at the airport, there's no doctor. It's a CISF constable who is now in a dilemma because he has been trained that during CPR, look at the chest movements of a person, check for the carotid pulsation. Now, a layman cannot understand all these terms like chest movement and carotid pulsation. If we will start giving CPR to this guy, for you and me as a doctor, it's gonna be, oh my god, why are you giving CPR to a person who is not requiring it? So that is what I mean by the word presumed cardiac arrest, that from a non-medico perspective, this person, he's definitely in cardiac arrest, though he does not require a CPR. Now, what will happen if you will give CPR to this person? Because for you and me as a doctor, this is going to be useless activity. But they have shown that even if you give CPR to this guy, it will result in minimal damage to the organs of this person. You see, a CISF constable does not know, or an ordinary layman does not know whether this is a genuine cardiac arrest or is it a presumed cardiac arrest. So they have mentioned that even if you give early CPR, a bystander CPR for presumed cardiac arrest, you will be able to save more people. Let me explain this once again to you. You are at the airport. You are physically there at the airport as a doctor. There's an elderly man. He's a known case of chronic stable angina. This person had suddenly palpitations and he collapsed. He developed a ventricular fibrillation. This patient collapsed on the airport floor and there was a call. And again, you see, one possibility is the doctor is available. Second, just to inform uniformity in this discussion, I am introducing a CSF constable once again. This chap whose 10th or 12th pass is once again giving CPR to the patient, and definitely if CPR is given on time, then recovery chances of this patient will be increased. You see, I've given you two scenarios. A is a person who's in presumed cardiac arrest from a non-medical perspective. B patient is a genuine person who's requiring a ventricular fibrillation. So what they're saying is that if you are withholding chest compressions in OHCA, listen to my words carefully. They are saying that if you withhold CPR in out of hospital cardiac arrest, both are scenarios of out of hospital cardiac arrest, the damage is relatively more as compared to the fact that there would be minimal damage caused to a person. Minimal damage. You see, a constable does not know what is A and what is B. He does not understand what is ventricular fibrillation. He does not understand what is hypoglycemia. For him, it's an elderly man who has collapsed. Should he decide, should he give CPR? Should he not give CPR? If we try to teach him too much, he's gonna get confused. He's not gonna understand anything. So we will say, give CPR. Whether it was required or not is a secondary aspect. If somebody collapses, you have to give CPR. So that is why they mentioned early CPR for presumed cardiac arrest. I highlight the fact that for a non-medical person to differentiate between these two conditions is not possible. For you and me inside the hospital, if I say IHCA, in hospital cardiac arrest, you and me can differentiate between this. But for OHCA, a constable cannot, or an ordinary person cannot understand this. So there's a distinct possibility that they get confused and they may not give CPR, and the more the time passes, because he's in a dilemma. In those circumstances, the chances of survival of patient number B would be almost 0%. And with A, what will happen? Minimal damage, maybe a broken rib, but at least something was done for this patient. So they're saying something is better than nothing. Additional aspect they've highlighted is with respect to training of doctors and again non-medical people for CPR. Here they've highlighted regarding the use of audio visual feedback. Mainly it's the audio feedback that matters, because when you're practicing on a dummy, you see, when the dummy software, when there's a talking software and it is telling you that the depth of the compression is not good, or you did not allow for chest recoil, in those circumstances the quality of CPR provided will dramatically increase. So they are saying that the health teams or whosoever is going to receive the training for cardiopulmonary resuscitation, the use of audio visual feedback to the concerned person, whosoever is going to learn the CPR process, will definitely increase his performance in a real-time scenario. Now, this is something that we are already aware of, so I would not like to say that this is anything important from the exam perspective, the 6th point, but then the previous points that I've said are much more dramatic and are definitely gonna require a bit of inputs from your side. He has also mentioned regarding the aspects of return of spontaneous circulation is always better if you monitor the ATCO2 of the patient. You are aware of the fact that return of spontaneous circulation can be monitored by 3 methods, that is end-tidal carbon dioxide values, diastolic blood pressure, and central venous oxygen saturation. Especially, I want you to remember this value of end-tidal CO2 values of at least 20 millimeters of mercury or higher will have higher chances of return of spontaneous circulation. So he's saying that when you're delivering good quality CPR, a high quality CPR to the patient, in those circumstances, if you monitor the patient with EtCO2, the chances of you getting a feedback of what you're doing right is more. Intravenous access is always superior to intraosseous access. That's the standard information we very well know. Earlier he was highlighting the fact that if a person is having a failed IV access, IV access is failed, then you can go in for intraosseous access. But now he's highlighted the fact that in some cases you can directly go for intraosseous access. Like for example, if it's a soldier and let me say both his hands were blown up, a grenade launched near him, and during the grenade explosion or mortar explosion, both his hands are injured. Now if both the hands of the soldier are injured, there is nowhere you can put a IV access. So in those circumstances, one, you can try a jugular access, maybe that also failed. So he's saying in those circumstances where there is no access available, it makes sense to straight away go in for an intraosseous access. So especially in military warfare injuries, if IV access is not feasible, he's mentioned IV is superior to intraosseous, no doubt about it, but he's highlighted the fact that when it comes to, he's not categorically mentioned military warfare, but he said wherever if feasible, then intraosseous access should be taken directly without having to go for an intravenous access. So these are some of small minute aspects that they have introduced in the current guidelines, and I would like you to go through this discussion at least twice just to get a hang of what are the minute changes that they've introduced and can be asked in subsequent exams. Thank you so much for hearing me out. Thank you for the patience that you've had to listen to me, and stay safe. Have a great day.